Good evening, everyone, and thank you very much for joining us at this 6th Stroke Research Innovation Education and Care seminar. Really pleased that you can all join us and to see so many of you with us from all across the UK today. So we've got an exciting evening ahead. First looking at innovative communications around stroke, and then moving on to hear from the newly appointed clinical lead for stroke in Wales and his vision for services in the future. So I do hope you'll tweet and retweet about the symposium via the Stroke Hub Wales Twitter handle that you can see on the slide. And please do type your questions into the Q&A comment box on your screen, and we'll try and answer as many as we can at the end of the event. So we're going to kick off with our graphic communication project designers, and I'll introduce you to the three of them. We're going to start this evening with Emily, who's one of our current level 6 students studying graphic communication with us in the School of Art and Design. Emily's a keen graphic design student who really enjoys a creative challenge, and I'm sure you'll see that in the work she's going to share with you. We're also going to hear from Luke, who's another level 6 student studying with us. His interests include illustration, design, football and playing the guitar. And then we'll hear from one of our graduates, Caris, who graduated with us with a first from graphic communications last year. Caris is interested in how design can be used to encourage positive social change and currently works as a freelance graphic designer. She's won an award from the ISTD membership for her typographic work and a Silver Creative Conscience Award for the Stroke project that she's going to discuss with you today. And all of our graphic design students and Caris have worked closely with Stroke Hub Wales, NHS Wales, Stroke Association and the NHS Welsh Ambulance Service Trust in developing these projects. So I'll hand over to Emily, who's going to kick off for us this evening. Thanks, Emily.
Hi everyone, I'm Emily, and the brief I was set was the Stroke Act Fast brief. I really love working on this brief as it was challenging but also really fun and engaging, and I'm very thankful to Abdul for the opportunity to present it today. So what was my challenge? So when reading through the brief for the first time, the key thing that stood out to me was obviously relaying the Act Fast message. 7,500 people will have a stroke in Wales, and in fact 70% of those strokes could be avoided if risk factors are acted upon. Therefore, this message is key. Also, in light of the pandemic, many people do not call 999 at the signs of a stroke due to the fear of contracting COVID from hospital. 3,800 deaths occur in result of strokes annually. Therefore, my message is vital to make people act and call 999 no matter what. The target audience was to raise awareness amongst the public, but also targeting rural areas of Wales, therefore thinking about ways everyone can receive the message. And then the aim was also to inform people of the Act Fast symptoms and the importance of seeking help. The final thing I took from the brief was a stroke can strike anyone, anywhere and anytime. One key thing that stood out to me in my first meeting with Abdul was time is of the essence. Time really is key to a stroke and can really alter the consequences of life and death. This led me to my concept of snooze. Would you snooze a stroke? The snooze button is a relatable and recognisable feature that many people will relate to. The amount of times you've probably snoozed your alarm when you're supposed to be getting up. You can't just snooze a stroke, you need to get up and act fast. This can also help bring in that younger audience through the phone-related concept, as strokes are often associated with the elderly, therefore showing anyone can have a stroke. The idea of the snooze button originated through the concept of time. I started to think of the ticking of clocks as a sort of countdown to an alarm going off, just like a stroke. There is a window in which you need to act before it is too late. You can't snooze a stroke, you need to act fast and now. 2 out of 3 people leave hospital with a disability after a stroke, and 38,000 people die from a stroke a year in Wales. Therefore, you really can't snooze a stroke. Don't wait, it's too late. I chose to make a video as my key concept for this project, as it really demonstrates the impact of a stroke through video and sound. I researched into the Act Fast symptoms, the face, arms and speech, and provide realistic imagery of how these will look to make them more recognisable to people so they will notice them and can identify a stroke. The sound of the clocks and the final snoozing of the stroke as an alarm is turned off really hits home and adds that dramatic impact to how important it is to act quickly. You only have a certain amount of time before it can become life-changing. I also made a leaflet as an outcome, as my leaflet brings together all the information into a copy that could be displayed alongside screens showing my video in places such as GP surgeries, as well as being posted around rural areas of Wales. Many survivors are left with visual impairment, and research suggests that many can only see black and white as opposed to chromatic colours, hence my colour choices of bright colours in contrast to the black and white photography. I also want to present key statistical information through phone-related imagery to further reflect my snooze concept. I think this helps to visually break down information and make it more visually engaging and easier to process. The back page of my leaflet also really reinforces the Act Fast acronym to the face, arm, speech and time, and I also shown that through photography to identify the symptoms and also the text alongside it. I've reinforced the message at the end that you must call 999. I also created an envelope to really target the rural areas of Wales so it could be used to send my leaflet across more people. A stroke is a very serious condition where the blood supply to part of your brain is cut off. It needs to be treated in hospital and as soon as possible. Therefore, again, I have reinforced the Act Fast acronym with a key focus on time. I also created more posters to go alongside my main poster in the previous slide to further reinforce the shocking statistics I had found. These posters could be held in GP surgeries or hospitals to create awareness or even rural areas of Wales. I have also shown how this campaign could be applied to social media, as this is such an effective way of reaching even more people. Someone could be scrolling and see, would you snooze a stroke, and I think the recognisable snooze button will really make them stop and think about this. These are some further social media imagery I have created, again focusing on visually presenting key statistics. These could be placed alongside my video on social media to reinforce the message even more. Thank you for listening. I hope you enjoyed looking at my work. I will now pass you on to Luke.
Hello, my name is Luke, and as said, I'm a level 6 student currently studying at Cardiff Met. I just want to say what an honour it is to be speaking at this event. So we were approached by Stroke Hub Wales to develop a campaign that promotes effective conversation between clinicians, the public and people with aphasia. The campaign required an educating and informing component, and working directly with clients whose role within health services has life-changing implications, we were challenged to demonstrate the power of graphic communication to transform lives. Our target audience were primarily the general public, clinicians, aphasia sufferers, family and friends. So at the beginning of my research, I was one of the many who had never actually heard of aphasia. And if you were one of these, aphasia is the partial or total loss of language comprehension and or language production. During my research, I came across this quote from an aphasic sufferer that said, "I knew exactly what I wanted to say, but my brain wouldn't give me the right word." And this really stuck with me throughout the project, as showing the break in communication that people with aphasia might feel. Also, I came across this fact that communication should be done in a place with no distractions, which really helped with my visual language to be minimal, to be simple, and to really push this no distractions. So I decided to create a campaign, obviously, to raise awareness on aphasia and to promote effective communication. I developed an icon specifically for aphasia that the public could recognise, and I'll go on to say why I did this later on. I had to also remember that the campaign was under Stroke Hub Wales, which led me to my colour choice. The colours that I used were inspired by Stroke Hub Wales' brand. Stroke Hub Wales used a red, white and black colour palette, but what I did was take the red and up the vibrancy, which really made the entire campaign jump out at the target audience. As I said, I developed a logo. The reason why I developed a logo or an icon for aphasia is that during my research I actually noticed that there wasn't an icon that was specifically for aphasia, and I questioned why this was and could there be potential for me to actually make one. So I created a logo that highlighted communication and aphasia, and as you can see, the logo depicts a speech bubble in the negative space of the A, and I used this speech bubble throughout my visual language. I decided to call the campaign aphasia.uk, and it has now come to my attention that a month after completing the project, the Royal College of Speech and Language Therapy, in collaboration with Stroke Association, have actually come up with a logo for aphasia, which is just great news. So I decided to also create a persuasive slogan, and the reason being is that the public in particular have to take on board the fact that dealing with an aphasic patient, it takes longer, and so they must not get irritated or frustrated, as that can make the person feel more self-conscious of their speech disability. This led me to my slogan, "Slow down, listen, be patient." I created a series of iconic characters that gave the campaign itself a very human approach without actually categorizing a particular age range or gender. The characters themselves are very friendly and approachable and really bring the campaign to life. My first outcome is looking at a kinetic bus stop ad. So the idea here is that it would start off by giving the definition of what a stroke is, then moving on to the definition of aphasia, and then moving on to moving on to the cause, and then moving on to a bit of information design. This outcome can then be applied across numerous touch points, such as train station advertisements, bus advertisements, and a booklet design. The booklet design in specific was designed for the general public to be able to know more about aphasia, know more about what Stroke Hub Wales are doing, and to actually get information on how to effectively communicate with someone with aphasia. This outcome then can be used across social media, as we're all on social media now. So what better platform to use than Instagram? Another outcome that I did was create identification cards and identification badges for someone with aphasia to wear or to show show that they have aphasia. Last but not least, I created an animation with the help of Nick Can, and what an inspiration it was to work with such a wonderful man.
Aphasia, language and communication problems. Isn't this intelligence? Use paper and drawing and write choices, gestures and pantomime.
Thank you for listening. I will now pass over to Karis.
Thank you, Luke, for that introduction. So today I'm going to be talking a little bit about my experience designing for stroke awareness. The first project I'm going to be talking about is titled Looking at Stroke. I think there's a general perception when it comes to stroke that you can only have one if you're a certain age. But of course, that's not true. In fact, 400 children on average will have a stroke in the UK alone. So this brief, I was challenged to create a campaign that would educate and inform young people around the age range of 16 to 21 about their risk of possibly having a stroke and encourage them to live a healthier lifestyle to reduce their chances. And while researching, I found this quite striking statistic. It's quite scary that 2/3 of stroke survivors are left with vision problems post-stroke. So these problems could be permanent or their vision might return. But anyway, as somebody who relies quite heavily on our eyesight in everyday life, but also as a massive part of my career, this really scared me. You know, you could go into hospital with, you know, perfect vision and come out maybe with damaged vision for the rest of your life. So although this was quite a scary fact, I thought it could be used to persuade and communicate to younger audiences who are typically more reliant on digital means of media. So I decided to come up with a set of glasses. These sets of glasses would be sent to schools around the UK, and they each replicated a type of visual impairment experienced by stroke survivors. So the first one, the red and the green glasses, are a type of hemianopia. So we have a central tunnel vision hemianopia and then a one-sided one. And then the yellow glasses are a type of scotoma where you lose the center of your vision. In terms of visual identity of the campaign, I wanted it to be quite bright and quite vibrant to encourage the target audience to engage with it. But I also wanted it to have some weight to it because it is quite, obviously a serious topic. So I chose 3 primary colours, the yellow, the red, the blue, but then weighted it down a little bit with a more muted green. So the combination hopefully gave a sense of enticement, but also a sense of seriousness. And in terms of extra visual elements, I created 4 separate shapes that represent a type of visual field loss. So you can see the circle represents a total field loss, a scotoma, a half field loss, and a quarter. So these shapes were used throughout the outcomes to further make the point the campaign wanted to make. And in terms of typeface or font, I used Stratos, which is highly geometric. So again, it links with the idea of the circles, but also, and more importantly, it's highly legible. So it made this project as accessible as possible to the most amount of people. But then I think there was a danger with this project still. People of that young age range, 16 to 21, could put on these glasses and engage with their surroundings, have maybe a fun time, but then so what? What would they learn from it? What would they take away? So I decided to really make sure they got that message of why these glasses are there, to use a form of data design in their presentation. So you can see here the cover of the glasses, there are a bunch of dots. And the 400 white dots you see there represent the 400 children who will have a stroke in the year in the UK alone. The 267 blue dots represent those who will have visual impairments post-stroke. The 200 yellow dots represent those who will need care post-stroke. And the 80 dots you see on the side represent those on average who will pass away after their stroke. This data is then explored in the inside of the leaflet next to the glasses, along with additional information such as what is a stroke, why the glasses again are important, and the third and most important point, how to reduce your chances of having a stroke. But again, then I was thinking logistically, if these glasses are sent out to schools, how will teachers know how to use those glasses and implement them effectively in their teachings? So I decided to create a leaflet/poster that could help inform tutors. So when this is folded, you would see stroke can occur at any age on the front, and on the reverse side, on the back, you would see these two paragraphs at the bottom that would have the information that they really need to know about stroke. So easily accessible information that they can tell the class. When it's on its own, you know, folded out, it could be used as a poster in school corridors, so that's another use for it. And on the back, you can see there's a lot more information that's more in depth about the campaign aims, again, the statistics, some information about how it could be used in schools, some safety precautions, and some concepts for workshops. And to quite literally wrap the whole project up, I decided to create some packaging that could, that you could send all the supplies out to schools in. So again, it uses the visual language, and and this is a photo of my friend and I testing the prototypes of the glasses. And Creative Conscience is an award scheme that rewards creative projects for social benefits. And I was absolutely thrilled, as said previously, to receive a silver award for this project. So the next project I'm going to talk about is titled Be a Hero. And it's a little bit different to the rest of the seminar in that it's not focused so much on stroke. It's about more about the coronavirus. So Stroke Hub Wales was approached by a nurse and told that children towards the beginning of the pandemic were quite scared of the sight of adults wearing PPE. So we were asked whether it was possible to create a campaign on an outcome that could educate young children about why PPE is important and maybe encourage them to wear it themselves. So for me, I started with the project of how I could communicate such a complex topic to young children. So I thought, is there a comparison that could be made? And what eventually came to my head was the idea of medieval knight helmets. You know, it's a form of protection that was worn, and it's instantly, I think, a bit more understandable to young audiences than PPE would be. So I started to develop this narrative that contemporary mask wearers are heroes. So we came up with the slogan, wear a mask, wash your hands, be a hero. And the main part of the campaign is an animation, but you can see I've also made some social media outcomes here. And the overall aesthetic of this campaign was quite papery, paper crafty, so highly approachable to young audiences. And again, really importantly, some legible typography being used, so easily readable, so that it could reach as many audiences as possible. So now we're going to watch the animation, hopefully.
For hundreds of years, people have been wearing specially designed outfits to protect themselves from danger. These days, we are no different. To protect themselves from the COVID-19 virus, adults wear masks, gloves, and face shields. However, to defeat our new enemy, we need your help too. Wear a mask, wash your hands, be a hero.
And the last project I'm going to talk about today is for this trichochord choir. So originally I was asked to create a short film about a study Stroke Hub Wales was conducting. Now that study changed paths, but we were still left with all this footage of interviewed stroke survivors that frankly was so powerful and we thought could really be important. So for those of you who don't know, the trichochord choir is a choir and a space where stroke survivors can go and engage and have fun and it is such a wonderful community. So we thought with this footage of people talking about their experiences, it could be used in a really positive way. So we decided to create an advert to encourage stroke survivors to join the choir. Now, this is especially important during a pandemic. Even if it might be the end of the pandemic, we want as many people to get involved as possible, as it's such a positive space. And it's especially important for those with aphasia. You know, it's been proven time and time again that singing is really beneficial for communication. So yes, without further ado, here's the video.
Well, I'm the musical director of the choir and started it in October 2014. I think with any choir singing together, it's community based as well, which is really, really good. Just singing in choirs, just people being together, and rehabilitation, music therapy through singing is extraordinary, really. Having heard the choir members for the last 5 years since it started, the difference in their voices is massive, and their speech as well has improved, and their singing has improved as well.
After my stroke, I was despondent. You know, there was nothing I could do.
Yeah, lost, I think, maybe.
Smile.
Just elated, I think.
Happy, yeah. No, it's better than happy.
The choir and stroke things are more my family now than anybody else.
A real positive from it has been the number of stroke survivors that have been encouraged to come to this that haven't been able to get to the choir in Cwmbran.
Yeah, it's a coming together, I think. I move house, so it's harder to come, and people fantastic to give me lifts, but it's a lot to ask, you know, and I couldn't join the concerts and things because the distance. So now Zoom, oh my gosh, is amazing because I can join in, see them, more people. Sometimes dismal weather, pandemic, and everything is, it can easy not to come, but then it takes its toll. Slowly go down, down, down mood, and then you kick and come back, and it's my God, why didn't I come earlier?
And the theme of the Stroke Accord Choir will be explored even more in the next symposium. But for now, I'm going to say thank you, and I'm going to pass it back to Katie.
Thank you, Emily, Luke and Karis, for sharing with us your thought processes about how you worked on these briefs and developed these really effective and impactful communications. It really struck me this evening watching it, the choice of colour and how vibrant all these presentations were. It was absolutely fascinating, so thank you all. And I'm now very delighted to introduce to you Dr. Shakil Ahmed, who's going to give us an overview of stroke care in Wales and hyperacute stroke units. Shakil is the newly appointed clinical lead for stroke in Wales, and also the clinical lead for stroke and training programme director for stroke at the Cardiff and Vale University Health Board. So it's really exciting to have him here with us this evening and to share his vision for clinical services for stroke going forward. So without me saying anything more, I'll pass over to Shakil and let him share his vision with us.
Okay, thank you, Katie, and thank you for inviting me this evening to share this talk. So When I was appointed back in October, November, I gave a talk at the World Stroke Day, and sorry, let me just see if I, yeah. And at that time, my daughter came up with this acronym, and she said to me, she said, look, Daddy, you know, if you really want to have an impact, you know, you need to have solutions, you need to work as a team, you need to take responsibilities, you've got to look at opportunities to improve care, and you have to have knowledge and empathy. So that's my little daughter, Hannah, and I thought, wow, what can I say? So, you know, I had to give her the compliment for that. So that's a real encouragement for me. So what I'm going to do in today's talk is talk a little bit about some of the bits about prevention and some of the care and the hyperacute and acute care. And you can see that this is, you know, our stroke patients, when they go through the care, they go through hyperacute, acute rehab and into the community. Now, we know that stroke services has evolved significantly. And when I was a junior doctor, and I started about 25 years ago, I remember very clearly that myself and this other houseman as well, we were called to the ward that there was a patient who was having a stroke. So we ran up to the patient, you know, we went to the bedside, and what could we do? Nothing. We just literally watched this patient have a stroke, and all we could do was just sit down and then examine him and, you know, write down exactly what happened, and then maybe a few days later, he might have a CT scan, and maybe he's given some aspirin later. So you can see that stroke services has really, really transformed, and I'm hoping to show you that in the slides tonight. So at the moment, stroke care consumes about 5% of our healthcare budget, and it's £2.8 billion a year. And if you take the indirect costs, it's about £7 billion a year. And we see about 150,000 strokes a year. It's one of the third leading causes of death, leading cause of disability, and it's predominantly a disease of those over the age of 65. And the mortality of stroke has been dropping. So we used to see about a third of our patients would have a 30-day mortality, and that's dropping down now to about 20%. And that's due to the good organised care that we have for stroke medicine. So firstly, I'm going to talk about atrial fibrillation. It's the commonest type of arrhythmia and increases your risk of stroke by about 5-fold. And 20% of our strokes are due to AF. But the thing is, with AF, it produces the most severest type of strokes. So from your heart, you have these big dirty clots that go off to your brain and block off your main arteries. And you can see from this chart that, you know, with AF, it has the worst outcomes as well. So what we want to do is we want to make sure that our pathways are designed so we can detect AF, protect people, make sure they're on the right treatment, and that's using a blood thinner, which is an anticoagulant, and perfect to make sure that we've got the treatment at the appropriate level. So back in 2014, the NICE guidance changed with regards to AF treatment as well. And previously we used to give aspirin, or we'd give warfarin, which is an anticoagulant. And NICE came out to say that aspirin doesn't have a role in the treatment of AF, because any benefit from giving aspirin was offset by the bleeding risks as well. So when this guidance came out, when we looked at that data, we saw that about approximately 1/3 of patients were not on appropriate treatment. So we've got a scoring mechanism called the CHADVAS score that if you use the mechanism, that it says that if you score 1 and above and you're male, then you should be considered for anticoagulation. And if you score above 2, then you should really be started on anticoagulation. And here's the criteria which shows you of all the various factors that we use for the CHADVAS score as well. And as you can see, as the score goes up, the risk of stroke goes up significantly as well. So the key thing is to make sure that we get the right patients on the right treatment. So I was really privileged to be part of a project that was funded by the Stroke Implementation Group and supported by the Stroke Association and British Heart Foundation and the Welsh Government to try and make sure that, you know, that those patients in the community, that they are appropriately treated with anticoagulation. And this project was basically bringing in primary care, so our GPs and hospital care together and working closely together. And that's the website there. So what we did, we set a website up, and it's got all the documents for all the various health boards. And if you go to the Cardiff and Vale website, you've got the GPs can access a secondary care physician, so a hospital consultant, by pinging a note on the e-advice system for any advice. And then you've got your FAQs, which is a fantastic document which answers all those really difficult questions about anticoagulation. You've got all the pathways and all the supporting documents as well. So the results from this project showed that, firstly, if we look at anticoagulation levels, you can see that the grey line shows that the number of people who have been anticoagulated has gone up. And this is data from 2017. And those people on warfarin has been dropping, but the new oral anticoagulants is going up significantly. And we felt that the project was having an impact on anticoagulation across Wales. One of the key findings that we found, which was quite astonishing to see, that 26% of patients were on aspirin, and then this dropped down to about 6% within that period. And what we are seeing now with the current data, this is fresh data now from January, showing that there's about nearly 60% of patients are on the new and oral anticoagulants, and about over 20% are on warfarin as well. So in Wales now, we can proudly say that nearly 85% of our patients who are at risk of having a stroke from atrial fibrillation are anticoagulated, which I think is a fantastic achievement. So coming back to the changes of stroke medicine, this is where we were before. This is where we want to be. So those who are car enthusiasts, that's a Bugatti, which is one of my son's recommendations. So, right, so it's important. So I'm going to talk a bit about the hyperacute treatment of stroke. So when somebody's having a stroke, time is of the essence, and we know that from Emily's presentation as well, that every minute counts. You lose about 2 million neurons a minute. And when you are having an ischemic stroke, you have an occluded area, and there's an area of damage, and you have a larger area which we call the penumbra, which is an area at risk. So if we think of this simply as just like it's a blockage in a pipe, what we want to do is we want to unblock the blockage there to restore blood flow as well. So we can do that by giving a clot busting drug, which is called thrombolysis, and this clot busting drug will just try and unblock those arteries. So the first trial that was done with regards to looking at thrombolysis showed that if you treat 100 patients with thrombolysis, you'll get 14 patients independent that would have been dependent. So it's a very powerful treatment. You only need 7 patients to treat to get favourable outcome as well. And this chart kind of demonstrates those who would be independent, and also there's a significant proportion who do benefit from thrombolysis. But there are risks with giving this treatment as well. It can increase the risk of bleeding. So there are 1 or 2 patients where you can get harm will be done. But the key thing is that although you can give the treatment up to 4.5 hours from the time of onset, the key thing is that you want to give the treatment as soon as possible. So if you can treat within the first 90 minutes, then you're much more likely to see people becoming independent as well from that treatment. So this is a poster that was designed by my colleagues up in UHW. And what we're trying to say is, when we think about thrombolysis, it's the 10-10-10. So what you have to act fast. So what we say is 10 minutes to assess, 10 minutes to scan, and 10 minutes to treat. And we have to try and get the patient up to the ward within 4 hours. So what I'm going to share now is a couple of case histories to show some real life cases about with regards to thrombolysis. So back in 2010 is when we first started our 24/7 thrombolysis service up in UHW. And I had a patient who came in who's a 74-year-old gentleman who has a pacemaker. He went to the shop to do some shopping, and he came back, and on his way home he suddenly developed an expressive dysphasia. He was unable to get his words out, and he had a right facial droop, and he was quickly brought into hospital for assessment. So when we assessed him, we noticed that his condition was getting worse, and his aphasia was getting worse in the sense he was having difficulty to understanding commands as well. So what we did, we got a CT scan and we did end up thrombolizing this chap. So this is his first scan that shows that he's already got some previous old areas of damage from a previous stroke. So that made us think that, yes, he's definitely having a new onset and ischemic event. So therefore, we went ahead and we gave him the treatment. And as you know, so this little area here just shows us tiny bit of damage that was done from his original stroke. And this is what we call the Broca's area. And this is where your speech center is. But within 2-3 days, his speech has improved significantly, and he went home fairly, independently, made a remarkable recovery despite this small little area of damage. So we've probably reduced the area of damage that would have happened if he hadn't been treated. So the other thing is about what we call proximal occlusions. So this is where if a clot goes up into the artery and it blocks the major division of the artery of the internal carotid, or what we call the MCA. And the problem is that if you think of it simply, is the bigger the clot, the more difficult it is for the clot busting drug to dissolve that clot. And just think of it as pipes. If you've got a big pipe and you've got a large blockage, if you're giving any sort of chemicals to try and unblock it, it's going to be more difficult. So the data shows that, if we give IV thrombolysis, if you've got an occlusion at the end of your carotid artery, only 9% will open up. And if it's the first part of your MCA, only 33% will open up as well. And so the smaller the artery, the more effective the thrombolysis is. But if we use a mechanical device, so if we're just thinking like if we use, as if you're putting a rod into your pipes and you're just pushing the pipes open, then a mechanical device would open the arteries up in 84% of the people. So looking at all our stroke data, we think that there's about 10% of strokes are due to proximal occlusions. And, again, these are generally patients who we do find are in AF and they throw up these big clots blocking the arteries. So if we can open those arteries, then, we can save the brain. So here we are with the interventional treatment. So there's a whole host of new treatments out there. This is one device where it's called a solitaire device, where the radiologist would put a little catheter in and they open this little mesh up. And then what they do is then they pull the clot out as well. There's some new devices out as well, where they're just using suctioning as well to take the clot out as well. So that procedure is what we call a thrombectomy. And this is being rolled out. The NICE guidance says at the moment that in order to qualify to have a thrombectomy, you have to have some neurological deficit. That's the scoring system here. The modified ranking score has to be less than 3, so you have to be reasonably independent. You have to be, the onset of the stroke has to be within 6 hours, and you need to do a CT and a CT angiogram as well as part of the workup. But then there were 2 further trials done, which looked at if you did more complex imaging, such as perfusion scanning, then you can increase that time window up to 16 hours or even up to 24 hours. There's benefit of doing thrombectomy as well. So I'm going to give 2 more examples here. So there's a 74-year-old gentleman who presented, who went to the end of his garden, to his shed, and he had a collapse there. And his wife suddenly, noticed that, he was paralyzed on the right side. He was brought into hospital. He was completely aphasic. He had right-sided inattention. So he was ignoring the right side. So his eyes were deviated to the left. And then he was brought into the A&E. So we immediately scanned him. And here's the scan. So it shows that his eyes are deviated towards the left side. So there's something going on the left side of his brain. That little white blob is the clot that you can see in his MCA artery there, which we call the string sign. And again, over here, you can see that there's a blockage there. So he was given the IV thrombolysis at the time, and that was the licensed treatment. But unfortunately, despite being given thrombolysis, the clot, he still had a very large infarction there, which is a large area of his left MCA. So you can see it's devastating for this patient of ours to have such a big stroke, despite being given thrombolysis. And the outcome was that he ended up staying in hospital for about 6 months, needed a peg for a tube into his tummy for feeding, and he needed a hoist to be transferred, and his condition was very, very fluctuant as well during his stay. So exactly a week later, there's a lady, 75-year-old lady, presented in exactly the same way. She was out shopping on Albany Road, and then she had a collapse, and she presented with dense right hemiparesis, again aphasic, right-sided inattention, in exactly the same manner as the other gentleman did. And you can see in this scan the eyes are pointed to the left, the clot is there, and it's there. Oops, we'll go back to that one. There we are. You can see that that's a large occlusion, the white blob, as I'd say. So we gave the IV thrombolysis, and this we did in about 2013 or 14. This was our first thrombectomy we did. So we did a perfusion scan. So this is a bit more fancy scanning, and what that shows is that the blood volume tells us if the brain is alive, and this tells us where the blood flow to the brain is. So we can see a large area of the brain that is at risk of being damaged. And if we don't do anything, then we'll lose that section of the brain here. So from that data, this just shows again that there's, the clot is there. So we contacted our neuroradiologist, and he quickly went in and he decided to try and take the clot out. So this is an angiogram. This is your internal carotid artery. This is what we call the anterior cerebral artery. And over here, you should see some vessels here, but you can see there's absolutely nothing there. So there's a proximal stump, and that's where the clot is sitting. And you can probably see the outline here, and that's exactly where, the large MCA artery is, and you've got no blood flowing beyond that. So he's put the catheter in, and there you are. So once he's put the catheter in, he opens the catheter up. And, I think my colleague, Dr. Joshi, describes it in a beautiful way. He said when he opens the catheter, he restores blood flow and he leaves it there for about 5 minutes. And he said it's like allowing the brain to breathe. And what he then does is then he removes the clot. And you can see that that the blood flow is restored on the left side. So here we are before and after. You can see the difference there. So that's thrombectomy. So we did a repeat scan, and there's no damage on her brain. She was mildly dysphasic, but this patient stayed in for about just under 2 weeks, but effectively went home fully independent. Now you can see the difference in outcome between the two patients as well by how powerful the treatment for thrombectomy is. So what we're going to do is I'm going to talk about, what are our challenges in Wales at the moment. We know that stroke care, according to the Stroke Association, that by 2025, the cost will be about £1.63 billion a year, and that will go up to about 2.8 billion by 2035. But in the last 12 months, our thrombectomy rate is only 0.55%. Now we want to be around the 10% mark. That is the golden number we want to get to. And there are centres such as the Republic of Ireland who are got their treatment levels up to about 8 or 9%. The rest of the country, the UK, the average thrombectomy rate is under 2% at the moment. So there's a lot of work that's being done in order to increase our access for thrombectomy. 11% of our patients are only given thrombolysis. Now we want to have a minimum of 20% as well with our thrombolysis rates. Only 44% of our patients got to the stroke unit within 4 hours. And none of our hospitals have scored consistently what we call level A on a SNAP measuring score. So this is a peer review audit that's done nationally, and you're scored level A, B and C, D and E. So we want to see our hospitals, move up to a level A score. And there's a significant cost as well, as I said, per patient with regards to when they have a large stroke as well. So we have to ask the question is, what do we need to do in order to change the system? Now, Edward Deming, who was one of the fathers of quality improvement, said, your system is only perfectly designed to give the results that it produce. So we need to have a little rethink and see, how can we redesign our healthcare system for stroke? And some of the models out there that show real benefit is by having regional stroke centres working within a network fashion as well. So we're a population of 3 billion. and we're 800 square miles. And what we should be thinking about is having a regional hub around regional centres around Wales, spanning having a network where everybody is working for that stroke network. So moving away from the idea that you're not working for health boards, you're working for the stroke network, and you're crossing boundaries as well. And that's the big vision that we need to see how we can do that. And that would go right from the hyperacute care all the way through to the community as well. And the data has shown that if you have the regional centres, that you can get better outcomes. So London and Manchester have done this reorganisation with their HASUs, which is hyperacute stroke units, and it's shown a reduction in mortality by about 5% over 90 days as well. So this sort of model is proven and it works. The other thing what we really want to do is that NHS England have commissioned 6 centres to do thrombectomy outside a neuroscience centre. And what we should be looking at is, then developing Cardiff as a training centre. And when we develop these big regional centres as well, we can train the clinicians within those centres to deliver thrombectomy locally. So you're not dependent on one specialist centre, you could have the thrombectomy locally at your local regional centre as well. So that's where we want to go, so otherwise, if we don't change our model, I think that, the curve is flattening and we'll fall behind the curve. If we really do, look at this model and be very bold, fearless and move forward with this, then we can be ahead of the curve. And I really passionately believe in Wales, we should be thinking about becoming leaders in this field as well. So we've got the stroke delivery plan that we are planning to deliver start in 2022, which is March next year. We want to put a new plan together. And in that, we'll have comprehensive stroke centres at the heart of it. We want the cross-party group had done a number of recommendations for stroke, which we're adopting. We want to implement that. And we also want to set ourselves some targets as well, so we could be held accountable for the delivery of our new stroke delivery plan. So we're going to say that we're going to do an X number of thrombectomy, thrombolysis, 6 months review. There's lots of other metrics we can put into that. And also on the prevention side of things, we want to make sure that the Stop a Stroke methodology is implemented across Wales, and also focusing on areas of high deprivation to manage some of the risk factors such as hypertension as well. Because we know that COVID has unmasked, lots of health inequalities, and we can really focus on that. And the Stroke Association have produced a report where they interviewed a number of stroke patients and their carers, and they found that a significant proportion, over 50% of stroke patients in the community, didn't feel that they were getting the adequate care. And the carers had a significant amount of carer burden as well, and mental health as well. So I think that, we really need to see how we can support the patients and the carers physically and mentally out in the community as well. So what are our goals? If we can get a 10% thrombectomy rate, we will see 350 patients independent as well. And over 10 years, that will be a cost saving between 400 to 800 million pounds. That's £100,000 per patient as well. If we hit 20% thrombolysis rate, we'll get an extra 110 patients free of disability. If you treat within 90 minutes, that's a further 22% increase there. And if we deliver the care, as I said, in this hyperacute regional model, we'll see a reduction in mortality by about 5% at 90 days as well. And all the other metrics that we use for our SNAP scoring, etc., will all fall in place as well. And if we get our patients to the ward within 4 hours, we will save about 11,000 bed days as well. So there's huge opportunity for us that if we restructure our services and we deliver this, that we can get better care, and there's huge cost savings as well to the system as well. It's important that underpinning all this is that, we have a good education and research framework as well, and Anne is doing a lot of hard work with regards to promoting this, and it's really important that if we get the right structures in within our healthcare system, then we can build research as well on top of that as well, and it will attract good people into Wales as well. So what's our next steps? We want to develop a quality statement for stroke. which we're doing. I had a very positive meeting with Andrew Goodall, who feels that, you know, if we have the National Clinical Framework, if it's launched, then stroke networks would fit within that framework as well. So there's an opportunity there to move forward. And the Senate had voted, the cross-party group had done a motion, put a motion through just over a month ago with regards to putting forward a new delivery plan, and that has gone through the Senate as well. So we're going to use that as our framework to try and move forward with regards to the future delivery plan as well. The next things we're also doing, we're doing a scoping exercise to see what does good look like, and doing a gap analysis, because there's going to be various things that we need to put the resources in with workforce in order to deliver this model as well. And hopefully we'll have all that in the next stroke delivery plan. So if we all move forward together, as Henry Ford says, then success will take care of itself. Diolch yn fawr. Thank you.
Thank you so much. That was absolutely fascinating, and I can see a number of questions are coming in now. So without further ado, to give everyone a chance to ask all their questions, I'm going to ask Gwennan to let us see the first question, and we can direct it to the appropriate person.
Yeah, of course. So we've had lots of great questions coming through. So the first one here is directed at Emily. So this person says, well done, Emily. How long did you have to complete your project? And would you change anything about your project? And how did you deal with the time pressure?
So I think we had about 5 weeks altogether to complete the project. I deal with time pressure quite well, I think, personally anyway, but to deal with the time pressure, we had like milestones we had to work to. So I think we had to meet with obviously Abdul and everyone, and then work and establish our creative brief, and then create concepts. And then from there, we chose our strongest concept and then created our visual language. And then I personally created my own goals to manage my time on the outcomes as well. And then if I could do something else differently, or if I had more time, I think I would like to work with actual stroke survivors and maybe make it a little bit more personal. So I think I had the handwritten use in my work, so I could maybe get actual people to write that who are stroke survivors. I think that would work quite well.
Thank you, Emily. Gwennan, have we got another question that?
So yeah, this one is directed at Luke. So this person says, hi Luke, did you involve stroke survivors with aphasia in your research process? Would you have done this differently if you had been given more time on this?
Yeah, so we were approached by Nick Can, a aphasic survivor and aphasic sufferer, who was an absolute inspiration to us all during the project. If I was to do this differently, if I had some more time, I'd like to have included Nick throughout the actual campaign. Similar to Emily, I'd have liked some more personal stories from both Nick and perhaps other aphasic sufferers.
Yeah, that's great. Thank you. Look, I hadn't quite realised when I was listening to you and watching what a short time scale you guys had for these projects. It makes it even more impressive that you were able to do it in these tight time frames, which is great. Gwennan.
So I'm just going through. We've got another question again for both Emily and Luke. So Wendy says, well done, Emily and Luke. Very professional and a credit to our graphic communication programme. What takeaways from this project would you share with your peers? And what advice would you give other designers who may be working with stroke?
Wow. Thanks, Wendy. What advice would I give to my peers? Probably research. Research is the most important thing. I think I figured out where I wanted to go purely based on research. Wow. What was the other question? Sorry.
So what takeaways from this project would you share with your peers, and what advice would you give other designers who may be working with stroke?
What takeaways? I'd probably say that stroke can happen to anyone. I think from someone who's quite young, it's difficult to imagine that a stroke can happen to someone like myself, or to anyone.
Emily, did you have anything you'd like to add around tips for the students coming behind you getting involved?
Yeah, I think the most important thing for me again was research and communicating with Abdul a lot, because I think I picked up a lot of inspiration there. I kind of grasped the theme of the time and how important that was. So I think it's really important to communicate on a regular basis with the client that you're working with, and maintain that contact throughout the project. I think I met at least once or twice every week of my project. And then for designers, I think you just really need to grasp what the brief is asking and just try and communicate that in the best way as possible.
Yeah, no, I think both of you did, but you really grasped that concept of time, didn't you? You could sort of feel the sort of urgency particularly through the video campaign. It almost made you feel a bit nervous, as if you wanted people to move on, which I guess is exactly what you were trying to achieve. So yeah, that's great. Thanks, guys. And Gwennon, I'm relying on you to trawl through this. So what's the next one for us?
Yeah, no, definitely. So the next one here is for Karis, I believe. So someone says, love the use of the dots to show statistics in a visual and simple way. Was it hard to try and portray the seriousness whilst not making it scary for the 16 to 21 demographic?
Absolutely is the short answer. It was really difficult. But I think this project was on a very fine line, in that if the viewpoint of the project was too positive, I don't think the age range would have taken notice. And I think also the other way, if it was too negative, I think it would have been too overwhelming. So I had to find quite a fine point of balance between the two, and I explored that, through the typography, through even the layouts of the documents. I had to make it, quite airy and quite intriguing for young audiences, but as well, as you may remember on the leaflets, the statistics were the main thing, the statistics and the glasses. So I tried to keep it light and airy, but then as well make sure that the information that needed to be there was there.
That's an interesting challenge, isn't it? Getting the risk across, but not sort of making your audience so defensive that they don't actually listen to the message or just assume that can't be me. So I think you're right. It's a difficult balancing act to walk there. Yeah, I think you did that extremely well. How are we doing, Gwen? Another?
Yeah, so we've got another question here for Shaquille, and it says, when do you envisage the HASU will open?
Right. Okay. So we're in discussions. So each health board, they've got acute stroke units, and the HASU is about getting the right workforce. Okay. So ideally, we want to try and do that as soon as possible. So we're already having discussions about how we start putting these stroke networks together. And it's about consolidating the expertise in one area, because then that shows that has the benefit, best outcomes. I'd like to say as soon as possible, but I think we need to go through a process. We're going through a scoping process at the moment, and then there'll be a business case, and then we'll take that to Welsh Government as well, and to try and get that up and running. But I know within Cardiff and Vale that our HASU modelling was, we wanted to get something of the basis going, by the end of this year at least, hopefully, if we can get the right workforce in.
And Shaquille, do you think there's going to be a challenge at all with sort of that balance between a community delivery and then the demands of acute care? So if things got hectic in the stroke unit, would you get that? Do you think you'd run the risk of people being pulled back into acute care? My experience of working with diabetes is that used to happen an awful lot.
Yeah, I think that it's critical that that we get it right across a pathway, because one of the European journals have shown that a couple of things that have had the major impact for stroke, and from an economic perspective, is AF management, thrombectomy, and community rehabilitation. So we shouldn't really rob one area to try and support the other area. It's important that we have the right workforce across that area. Obviously, when there's demands on the service, you would try to see, try and put the right number of resources in to meet that demand as well. And that's why I think if we spread ourselves too thinly with trying to do the hyperacute treatment right across too many areas, and that's why if we consolidate it into regional centres, then the service is more resilient as well. And I think COVID has shown that our service, when we didn't have the pandemic, it was plodding along, but as soon as the pandemic came, it put it under stress, and and you can see where some services struggled as well. So we want to build in that resilience by consolidating the workforce.
Yeah, it's getting all those things lined up, isn't it? The politicians and the all lined up and sharing the vision. So yeah, hopefully there will be one open soon. That would be fantastic. Gwyneth, over to you.
We've got another question here from Wendy that says, Caris, what a journey. What would you like to do next?
Well, thank you, Wendy. I'm working as a freelance graphic designer at the moment, and ideally I would love to continue working on socially beneficial projects, specifically in healthcare, because I found quite a passion for it. But even generally beneficial projects I think would be fantastic. So hopefully that's the plan anyway.
I'm sure that events like this will encourage people to think about using graphic designers and to really improve their communications, because I think you've all demonstrated to us what a difference you can make in terms of the impact that these communications have. And I think that's a really important lesson probably for everyone in healthcare, definitely. Well, and how are we doing with our questions? So we've probably got time for one or two more, would you say?
Yeah, I think a couple more. So we've got another question, and I think this is aimed at Shaquille, that says, great evening, thank you. Do you have ideas on how the public can be influenced to understand the urgency of time treatment?
Yeah, I think that that having that campaign, for example, the Stroke Association are going to relaunch their FAST campaign again this month, and I think that we're trying to piggyback onto that. But it's really when those adverts did go out, it was quite powerful. We suddenly saw a spike in our admissions as well coming through, and it is really, and I thought, looking at the other people who've presented today is great. I think we should maybe using some of those skills and marrying that up in healthcare as well, because I think they've got fantastic ideas, great way of communicating and seeing how we can really get that message across. It's to really say that every second counts, and so the public need to identify that, and then we need to get the patients back into the hospital as soon as possible. So time is of the essence, is the key thing here. It's a bit different. The thing is with strokes, when you have a heart attack, you have chest pain, and it's you wake up in the middle of the night, you have chest pain. When you're asleep and you have a stroke, for example, it doesn't quite wake you up in that sort of fashion. So it really is trying to change that, and get people to understand and recognise those symptoms as soon as they suspect it, come in and get access to that. So
it's fascinating it did have that much of an impact, the spike on intakes. But did you get better out? Have you tracked that? Were those out? Did they come in earlier? Were they better outcomes for those patients? Is that a really impossible question to ask?
Well, so from the data, the quicker they come in and the quicker they have their treatment, because the thrombolysis treatment you can only give within that first 4.5 hours, you see, and if you present later, then you can't have the thrombolysis treatment. So therefore you'll have the natural progression of the stroke. So all the data that shows that that first hyperacute care coming into hospital, and those first 2-3 days that you treat in regional centres has a huge impact on outcome further down the line as well.
Fascinating. So one more, I think, Gwennon, is that right?
Yeah, so we've got a question here, and it says question for each speaker. So it might be interesting if we could just hear briefly from each speaker, if that's okay. And the question is, what's the most significant thing you have learned from working with Stroke Hub Wales, and what are you most proud about in terms of the products?
So who's going to go first? Emily, you're going to go first?
Yeah, that's fine. So I think the most significant thing for me that came from my project was the concept of time, obviously, because it's obviously really important to focus on time. It can be a matter of life and death. Getting to hospital in that window frame of time you have with a stroke can change your life. You could end up with disability, visual impairments, physical disability. So there's so much that can change your life, and if you act quick, then you could stop that from happening. So I definitely think that's the key thing I took from it.
Thanks, Emily. Luke, coming along to you. You're next on my screen. So.
I think the most significant thing for me was that we as the public need to recognise these ways of communicating with someone with aphasia. So I think that right now not enough people know about aphasia. I think if we raise the awareness, then more people, it'll become a common thing, and we could all actually communicate effectively.
That's great, thank you. Caris?
I think the main thing I learned was from the stroke survivors themselves. I mean, as part of the process, when I made my project, I was put in touch with, such an inspirational group of people, and just really taking the time to listen to their stories, their experiences, and what stroke really meant for them and for their lives afterwards. It kind of changed my perspective on the subject as well, because I think you can read about stroke and kind of learn generally about it, but it is completely different when you hear people talking about their own stories. So if I took anything away from it, it was that, and the fact that empathy is so important within design.
No, that really comes through from all three of you. Huge amounts of empathy in these designs have been fabulous to see. And Shakil, can we pass to you for a final comment and answer to that question?
Yeah, I think the first key things are, obviously the research and education is the key thing that Stroke Hub Wales has been doing. But from this evening, what I've really been taken back by is how amazing your presenters are. That they've been the work that they're doing and how effective that communication is. So I think there's an opportunity about linking in with the health service as well, or with Stroke Association as well, because I think that getting communication and message out there is the key thing as well. So I think collaborating with a group, I think would be is what I've learned from this event, definitely.
Thank you. And I've just been interrupted by Gwennon, who said, can we just ask one more? So go on, Gwennon, we'll just have one more before we wrap up.
Yeah, one just came in last minute, and I just think it's a really good one to ask. I'm sure a lot of people will be thinking the same. How can other organisations be connected up with these graphic students or year below to add their skills to develop, add value to our projects?
And I think, interestingly, I think that Wendy has put the way that you can do that into the chat. So I don't know whether you're going to be able to share that with everybody who's on this seminar now, where Wendy has given the details on how to get in contact with the programme. So that's really helpful, and it does just enable me to move quite nicely into saying that actually this, as we've been going through the seminar, it has been recorded and will be available to watch, because I understand some people had to come in through their phones. They haven't been able to watch it in its full glory, if you like. So there will be an opportunity for you to re-watch it, and we will also take a little bit of time after the seminar to check through all the questions and make sure that we have answered them all, and we will answer them on an individual basis if there's any that we've missed. So hopefully that will deal with any outstanding questions and opportunities for other people to access this fantastic seminar. So it really just leaves me now to say thank you first to our presenters, Emily, Luke, Karis and Shakil, for being just really fascinating and sharing all your work and insights with us. And obviously to Abdul for pulling us all together and making this happen. And this is the 6th seminar that he's organised. And finally to Amy and Gwennon, who've been the events manager and made it so simple for us all to do something that is really amazingly professional and remarkably easy for all of us. So thank you all very much. And finally, thank you to everyone who's come and listened. It's been great to have you with us, some fantastic questions. It's very strange doing it in this way, all in our own little rooms, but I think it's worked really well. So please stay safe and join us in the future, which we may be doing it online again, but perhaps we'll be back in a physical space with you sometime soon. So thank you all very much and have a safe journey if you are indeed travelling. Most of us, I think, are just moving from this room into the kitchen or the sitting room. So good night to you all.